You're on.
Okay. Hello, everybody. We'll just sort of we'll get ready. We are recording this session as well, just to let everyone know, just to warn everyone. Um, I'm going to be speaking today about some upper extremity conditions, as you can see up there. My name's Dr. Andrew Lingwood. I'm a specialist occupational medicine physician, and I'm one of the directors here at Occupational Consulting. We are a specialist occupational environmental medicine practice. We perform a combination of some clinical work, some work as treating specialists, but also a fair bit of independent assessment type work and medico-legal work as well. We work quite a lot in the workers' compensation setting, both in Queensland and in a number of other states. And as I said, I'm going to be talking today about some common upper extremity conditions in the workers' compensation setting. Now, we don't have the facility for people to ask verbal questions during the presentation, but if people want to put any questions into chat, I will try and get to those at the end. And my practice manager, who is moderating, will keep an eye on that for me as well. So I think otherwise we might get started. So firstly, look, thank you everyone giving up your lunchtime today. I appreciate you giving up that time to come and listen to this. I'm going to be talking today, as I said, about some common upper extremity conditions that we see fairly often in workers' compensation settings. So I'm going to talk briefly about what each of the conditions are. It's not really a clinical lecture, but we'll talk a little bit about what they are. Then I will talk a little bit about what sort of our current understanding is about how they develop. We'll try and talk about both sort of individual or constitutional type risk factors for the conditions and also external risk factors for the conditions as well. And depending on how we go for time, I might just go through a couple of slides towards the end about some general advice that I have for managing some claims for these types of conditions. So that's the basic plan for today. So the first thing just want to talk about upper extremity disorders in general. So upper limb musculoskeletal disorders are very, very, very common. They're very common in the general community. They're very common in insurance settings as well. We use our arms for many, if not all, jobs and day-to-day things around the house, hobbies, recreations as well. So, as I said, very common conditions in the population. So it follows that people are not infrequently going to become aware of arm pain in the course of their work. And the question, if we're looking at this from some kind of insurance perspective, or if we're a medical practitioner who's being asked to give an opinion on that, is what exactly is the relationship between this condition and the person's work? And there's lots of difficulties in terms of drawing that conclusion sometimes. A lot of these conditions that we sometimes see, they're not very well defined. They might have quite unclear diagnostic criteria. I think about terms like RSI or repetitive strain injury or OOS, occupational overuse syndrome. I mean, to some extent, even the title that I put up there, work-related upper extremity disorder, it's quite a non-specific term which does not identify a particular type of pathology. So, that makes it very difficult to sort of work out what's going on and work out any relationship to work or other activities. The other thing that makes a lot of this difficult is that the relationship of a lot of these conditions to physical activities, and those physical activities might be at work or they might be outside of work, it's still of some conjecture. Um, it's very common that people who have got some of these upper extremity conditions will experience pain or other symptoms in their arms whilst they are doing things at work, but it doesn't automatically follow from that the condition has been caused by these activities. There's also a whole lot of coexistent non-activity related factors. And so unpicking all of this can be quite a mess. Um, so what sort of conditions are we actually talking about here? Now, I'm a categorizer. Lots of people are categorizers. So we often do categorize, these work-related upper extremity disorders, and you might categorize them different ways. I sometimes like to think about a distinction between conditions which represent specific diagnoses. So things up there, which as you can see, they've got defined clinical findings or radiological findings or certain test results or diagnostic criteria. These might be things like the neuropathies. So like carpal tunnel syndrome has particular neurological findings on examination and characteristic nerve conduction study findings. Relatively good condition to diagnose. Tendinopathies up there, they've got sort of fairly characteristic radiological appearances and sort of clinical findings as well. But individuals can also present with more non-specific symptoms. So these are, just arm pain or discomfort or fatigue. These symptoms, they can be used to help us come to a diagnosis, but until we can actually get a particular diagnosis, it's very hard to either treat the condition for one or in the insurance setting to work out what's likely to have caused it. So what are some of these conditions that we're talking about? There's a whole bunch of common upper extremity conditions which are fairly frequently attributed to work. This is certainly a non-exhaustive list. Now, you'll notice here, like, I'm not including things like broken bones. I'm sort of deliberately excluding sort of clear-cut traumatic pathology. Like if you've got a broken bone from a fall or a laceration from a cut to the arm, then, it's a lot easier to sort of work out what's caused that. A couple of points to make about this fairly long list is that one thing to always remember is whilst it's not part of the upper extremity, the neck is an important potential source of upper extremity pain. So doctors always need to be thinking about the neck, particularly if you've got cases where both arms are affected by symptoms. We can then essentially work our way down the limb. So in the shoulder, we've got pathology like rotator cuff pathology. We can then move down to the elbow where we have the medial and lateral epicondylitis type pictures. We can get nerve compressions around the elbow as well. We can then move down to the wrist and hand where there's a variety of types of tendinopathy or tenosynovitis. We can also get nerve compression there as well, like carpal tunnel syndrome. We can get things like ganglia in all sorts of parts of the arm, and arthritis as well can affect all parts of the arm as well. Now, we're going to pick out a few of these to talk about in a little bit more detail. So the first one is good old carpal tunnel syndrome. So carpal tunnel syndrome, it is the commonest, what we call a compression neuropathy, which means a condition whereby a nerve is being squashed and the person gets symptoms related to the function of that nerve after the point where it's squashed. So it's a really common workers' compensation claim. Now, apologising in advance here, looking at this slide now, I can see that it's a very busy information-heavy slide, and I've got a couple of these coming up. I think in hindsight, I probably should have split these into a couple, but I kind of wanted to keep the picture and the text on the same slide. So I'll apologise in advance, and I'll try and sort of unpack these slides. So carpal tunnel syndrome, as you can see up there, refers to a group of symptoms related to compression of a nerve called the median nerve as it goes into the hand through an anatomical tunnel in the wrist. The nerve can be compressed in there due to a bunch of anatomical factors that can make the tunnel small, but there are some other physical activities which might be associated with it as well. We often talk about tasks requiring frequent or sustained or repetitive use with the same or similar movements of the hand over prolonged periods of time. Awkward hand positions, particularly things like a lot of use of a pinch grip for extreme flexion or extension or ulnar deviation of the wrist, use of the fingers with the wrist flex. So if you've got the wrist flex, you're using the fingers there as well. These are some positions that are likely to put more pressure on the carpal tunnel. Regular use of vibrating or handheld tools can affect the condition as well, as can pressure over the base of the palm. So people who are sort of pressing down on there for a long period of time can also compress the nerve a bit further. So what I'm going to be doing with each of these conditions is I'm going to go through what we think about to be some occupational risk factors and then also some non-occupational risk factors. Now, when I'm talking about occupational risk factors, I'm kind of sort of trying to collate a few different references here. There's a book called the AMA Guides to the Evaluation of Disease and Injury Causation. There's sort of a database for physicians called Up to Date. and sometimes some advice from organisations like the American Academy of Orthopaedic Surgery and other sort of fairly famous or big clinics in the US that provide some information. Now, a couple of general comments about these evidence statements up here. You can see that a lot of these points they talk about, strong evidence, some evidence, low risk evidence, that sort of thing. So, I mean, these levels of evidence that they're talking about here are predominantly coming out of that AMA book, and they're based on reviews of evidence that have been formed by those authors, and they sort of set their own standards as to what they consider different degrees of evidence. It should be noted that book is about 10 years old now, and the definitions of evidence that this book uses don't necessarily cross over into, say, the Queensland Workers' Compensation System, which, as many of you know, it has quite a low bar for the entry or acceptance of a claim. A condition only needs to have work as a significant contributing factor. It doesn't have to be the most significant factor. It just has to be a factor. So whilst, you see things like some evidence being strong, some being low risk, that certainly gives you an impression as to the relative strength of the evidence. But just because there's sort of lower levels of evidence for something, it doesn't necessarily mean that it's a condition that's not going to be accepted in the workers' compensation system in Queensland. So I'll kind of, make some annotations or qualifications to some of these statements as we go. But with that by way of background, so carpal tunnel syndrome, I talked before about that sort of combination of force of repetition, force and posture, and there's fairly strong evidence for those types of conditions. What does that actually translate to, though? So we're talking about extensive manual exertion of the hands and wrists. We're talking about things like meat packers, assemblers, butchers, carpet layers, really strong, forceful use of the hands there. I mean, highly repetitive work is another thing that's often spoken about. There's conflicting evidence here because there's, people define what is repetitive differently. There are some things that certainly aren't associated with carpal tunnel syndrome from a causative perspective, like keyboard work, for example. I mean, typing does not cause carpal tunnel syndrome. It's a repetitive task, but not just any repetitive task. There has to be sort of those degrees of force and posture, from my perspective anyway. One of the interesting things about carpal tunnel syndrome is that, psychosocial factors, satisfaction with work, actually have fairly decent evidence of a relationship between them and carpal tunnel syndrome as well. And you'll see that in a few places as well. We know that carpal tunnel syndrome patients tend to do worse if they're being treated in the workers' compensation system than if they're being treated outside the workers' compensation system. There are, of course, with carpal tunnel syndrome as well, a whole bunch of significant constitutional or non-activity related risk factors. So age and sex, just being sort of a middle-aged to older female is a significant constitutional risk factor for carpal tunnel syndrome. If you add into that significantly increased body mass index and diabetes, you're getting really, really, really at high risk of carpal tunnel syndrome, irrespective of what type of work you do. I mentioned before the biopsychosocial factors are very strongly linked with it. Genetic factors and family history are important as well. Some people might have a congenitally smaller tunnel, which makes it more likely to have that. There is a bit of evidence about smoking as well. This point down the bottom about the dominant hand, what we're talking about there is a condition more likely to be present in the hand a person uses more frequently because it's their dominant hand? And there's not a lot of strong evidence that that is the case. So there's a bunch of non-occupational things that really should be being looked at by any sort of claims manager or doctor who's providing an independent opinion on the causation of carpal tunnel syndrome. I'm going to move on next to another common condition around the hand and wrist, de Quervain's disease. So this is a condition where some tendons, they're called the APL or abductor pollicis longus and the EPB or the extensor pollicis brevis, on the thumb side of the wrist, so over here, become thickened and painful as they go through some little tendon sheets going into the hand, as you can see in the diagram there. It is a condition which is fairly frequently attributed to repetitive activities, again, be they at work or away from work, particularly postures involving maintaining the thumb in so extension or abduction, so these movements. But when we're trying to do sort of prospective studies on this, however, there's not really a clear or definitive relationship with these. In terms of the things that we think might be associated with this condition, so again, if we've got like a combination of risk factors, so if a person is performing forceful, repetitive tasks in awkward postures, there is some evidence for that. And I'm particularly interested here in individuals who are doing lifting with the hand in what we would call neutral for pronation and supination. So that means that the forearm is out with the thumb side facing up. So if you're sort of doing lifting, this sort of lifting particularly, firstly, you should not have people trying to lift in this position because that's very bad. You should also be lifting, using the large muscles, not the little muscles down this side. But that's particularly something that's likely to flare up this condition. Other than that sort of highly forceful or repetitive work, there's again not a lot of evidence for other factors in the course of work for this condition. There are again a bunch of non-occupational risk factors. So age and sex are certainly important. Diabetes and some of these other factors that are commonly implicated in carpal tunnel syndrome, however, the evidence for these isn't as great. I mean, you'll certainly find some references suggesting that diabetes and smoking can contribute to any of these sort of tendinopathy type conditions, but the evidence for them is not as great in de Quervain's disease as it is in, say, carpal tunnel syndrome. So, moving up the arm a little bit to lateral and medial epicondylgia. Now, a bit of nomenclature to talk about here. I am talking about tennis elbow and golfer's elbow here. And these conditions go by a lot of different names. So tennis elbow, which is the pain on the outside of the elbow, the thumb side of the elbow, sometimes known as lateral epicondylitis or common extensor origin tendinosis or lateral epicondylgia, or medial epicondylitis, golfer's elbow, which is pain on the inside of the elbow, also known as common flexor origin tendinopathy or medial epicondylgia. So these conditions refer to pain on the inside or outside of the elbow. We know now, though, that this relates to a chronic microdegenerative or breakdown, wear and tear type process in these tendons where some of these muscles from the forearm insert into the elbow. It's not thought to be an acute inflammatory condition anymore. There are, again, some types of physical exposures that can contribute to or aggravate this condition. We're talking about, again, highly forceful, highly repetitive, highly awkward postures. Frequently lifting loads around that 20-kilogram mark is also an example commonly given. If you directly whack the outside or the inside of the elbow, you can again flare this condition up as well. The slide down the bottom talks about tears in the tendons there, and certainly if you image the elbows with this condition, you sometimes see partial thickness tearing there. These very rarely, however, actually represents like an acute tear and injury to the tendon. It's much more likely to be part of that general microdegenerative process where the tendon sort of becomes thickened, fibrotic, and then you start getting these little tears in them. It's one of the problems that we have with our really excellent radiology now. We can see these things, and it can be very hard for people to get past the fact that a tendon has a tear in it and they want to try and fix the tear, when in reality, the tear is not going to be fixed. The tear is part of a general aging process. This is excluding, of course, excluding the possibility of there actually having been a major traumatic incident or a major cut there that has acutely damaged the tendon. These sort of intrasubstance tears, they are part of the normal aging process. So what are some of the risk factors we know about for this condition? Again, I talked about some of these combination of high forceful activities. Again, if we look at other things, though, the evidence is not as great. Again, for most tendinopathies, a lot of people would say things like diabetes and smoking are, but people in the AMA don't find a lot of strong evidence for that. You'll see down there again, like keyboard work, typing again. It's not a condition it's not an activity which causes any of these upper extremity conditions, but it's a condition that people will be aware of pain in the elbow or their wrist if they have an upper extremity disorder where they're typing. which is where it gets important to try and separate out what is a setting in which someone's experiencing these symptoms as opposed to when is the activity at work actually causing the condition. There are a bunch of non-occupational things there as well. And as you can see, the evidence for them, again, it's not as great. Like, I'd put a bit of an asterisk next to the age and the diabetes and the smoking here, just in the sense that older people and diabetics and smokers are definitely more likely to get tendinopathies. But when the people doing this AMA guides to the evaluation of disease and injury causation were putting together theirs, they didn't consider enough evidence to cross over their threshold. But, I certainly do consider those to be relevant factors when assessing a case of tennis elbow. Another thing that can happen at the elbow, and apologies, this is a very busy slide again, just to try and fit that picture in there, is something called ulnar neuropathy at the elbow, or cubital tunnel syndrome. And this refers to another, what we would call an entrapment or compression neuropathy, whereby a different nerve this time, the ulnar nerve, gets restricted or impinged upon as it is going around the back surface of the elbow. So as it's going around the inside of the back surface of the elbow there. This is what happens with when you hit your funny bone. When you hit your funny bone, you're hitting that part of the elbow, you get a jolt down that ulnar nerve. So ulnar neuropathy at the elbow basically feels like a chronic funny bone hit to varying degrees of severity. This is a condition which, whilst with carpal tunnel syndrome, there are certainly some fairly well-defined activity-based things, be they at work or otherwise, that can cause it. Ulnar neuropathy is much more strongly related to anatomical or underlying constitutional factors. So there are a bunch of things around the elbow, these fascial bands. I'm not sure if you can see my mouse on the screen, but these sort of white areas around it, these are sort of fascial bands which sort of form roofs of these tunnels and things like that. They can be more pronounced in some people, and they can be more likely to press on the nerve. If you've had any broken bones or fractures around the elbow and you've been left with a bit of deformity in the elbow, if you've got, again, tumours or ganglions in this area. So if there's anything in this area that's taking up some of the space, that can contribute to this condition. If you have people who are for long periods of time leaning on their elbow on a desk, sometimes when I'm on a plane, I know that I've got my hand on the seat next to me, my arm on the seat next to me. I can sometimes get a bit of tingling in my fingers there. So pressure over there can certainly exacerbate the symptoms of this. And being a neuropathy, again, things like diabetes, cigarette smoking, underlying inflammatory disorders can certainly contribute to as well. So in terms of the occupational risk factors, again, there's not like a lot of strong evidence for occupational risk factors for ulnar neuropathy at the elbow. Certainly things like keyboard work are not considered to be significant risk factors for it. If you are leaning on that elbow, you might sort of exacerbate it. If you're doing a lot of flexion extension movements of the elbow under load, again, you might stir up the symptoms related to it, but it's a condition that I don't often see that I think is, significantly related to work. There are, again, evidence there about increasing age, diabetes, and smoking. So a bunch of these constitutional factors are really important in ulnar neuropathy at the elbow. Okay, so moving a bit higher up again, let's come to the shoulder and let's talk a little bit about rotator cuff tendinopathy and impingement syndrome. Now, this is, again, we need to talk a little bit about some nomenclature and naming, because this pathological process goes by a lot of different names: rotator cuff tendinopathy, rotator cuff tearing, impingement syndrome, bursitis, bursopathy. There's a whole bunch of things referring to a similar pathological process here. And this process relates to chronic changes in the muscle tendons around the shoulder. Just like those tendons around the elbow can gradually wear out, get a little bit more fibrotic and fragile as you get older, the tendons of these rotator cuff muscles can. And they are particularly susceptible to this in the shoulder because, again, I'm not sure if you can see my mouse, but if you look at the supraspinatus heading, you can see it pointing to a white bit, which is the tendon attaching into the humerus here. And if you follow that further back, you can see the sort of more pinker area, which is the muscle. You can see the muscle and its tendon. It travels under this sort of tunnel here in between the acromion, which is the bony bump on the front of your shoulder blade, um, in between the top of the humerus and your AC joint around here. So it's going through this little tunnel. It's got this bursa here, which is there to try and let the tendons slide back and forth. The bursa is just a very thin fluid-filled sheath that works on the principle of sort of like that capillary effect. If you have two small sheets of glass, put them together, they're very stiff to move. But if you put a tiny drop of water in there, they'll move move very easily. That's what the bursa is there for. But because that tendon and a bunch of other tendons go through that space, they are subject to being rubbed on and gradually wearing down. You can see there that there's been a long debate regarding the importance of extrinsic factors as opposed to intrinsic factors. So intrinsic factors relate to things like age-related degeneration, poor vascular supply to the tendon, variance in that anatomy, so that if this acromion process, if it tilts down further and makes that space narrower, you're going to get more rubbing on those tendons there. Everything wears out as we get a bit older as well, but we do certainly accept that for this type of rotator cuff pathology, if people are performing frequent, sustained or forceful activities above chest height, greater than around about, we say about 60 degrees of flexion or abduction. So that's essentially 60 degrees between your torso here and here. So this would be 90 degrees. Here's greater than 90 degrees. There's less than 90 degrees. So anywhere at or above chest height, if you're doing a lot of activities there, you run the risk of either causing some progression of this condition if it's done for a long time, or flaring up symptoms related to it. So there again, bunch of occupational risk factors, definite incontrovertible evidence that if people are doing sustained sort of greater than 60 degrees or so of flexion and abduction, that is going to flare up this condition, particularly if you add in a bit of force and repetition to that as well. Smoking again, I'm not quite sure why smoking here is here. My apologies, that's an error. That should be on the next slide about non-occupational risk factors. But again, keyboards, I keep drawing the attention to keyboards because, you know, we do frequently see claims, people saying that working in an office or computer-based position causes these things. There really isn't any good evidence to suggest that rotator cuff tendinopathy is caused by keyboard work. That is work typically down around waist height. Again, if you've got a really sore shoulder, you'll have some pain while you're typing, but keyboard work does not cause rotator cuff syndrome. Going over to non-occupational risk factors, yes, smoking has crossed over there, sorry. Again, as you get older, if you've got a high BMI, if you've got diabetes, if you're a smoker, these things are all relevant. You can see there it talks about anatomy as being low risk evidence. This again just comes back to the fact that when these people have done their evidence review, they've set their standards at certain heights. Most people would say that if you have got what we might call a curved or a hooked acromion, which is where the tendon is, that bony bit points down a bit more, that is likely to be a significant risk factor. So, as we're coming towards the last couple of conditions, I think, let's talk a little bit about ganglia or ganglion. So ganglia, which is the plural for ganglion, these are common soft tissue swellings, typically around the wrist. They can occur in other joints as well. We can get them around the elbows and all bunches of other joints as well, but classically they're on the wrist. They're often on the back of the wrist. A person will have a bump on the back of their wrist there that they can see. They are typically benign underlying lesions. They are thought to arise from some of the tissues surrounding the joint, like maybe the joint capsule or its lining, some of the ligaments or tendon sheaths around the joint, and they're often filled with synovial fluid, which is the fluid that lubricates our joints. Now, we don't know exactly why they develop. Sometimes they occur completely of their own accord. Sometimes they do follow trauma. So if a person has a tear in a tendon or a ligament around the wrist and a ganglion develops subsequently, most of the time, most doctors are going to accept that that is a consequence of that, acute trauma tear. But as I said down the bottom here, they are also common findings. They can appear, they can disappear, they can change size fairly quickly in the absence of any apparent triggering factors. And the really important thing to note there as well is that they may or may not be symptomatic. The fact that a person with wrist pain has a ganglion is certainly something that's interesting and worthwhile looking into, but it certainly doesn't automatically mean that the ganglion is the problem. You can get into this situation where, you know, maybe I need to remove it, maybe I need to inject it or something, but in the end, it's got nothing to do with the symptoms, and sometimes that treatment or surgery can cause further problems in and of itself. So ganglions you would typically leave alone unless you have a very good reason to think that they are a cause of a person's symptoms. Now, in terms of are they related to work, I mean, the short answer from my perspective is unless there has been a work-related injury to one of these surrounding structures, the answer is no. I mean, they're not just caused by repetitive use. They're certainly not caused by keyboard work. Really, the only way that I would typically consider attributing a ganglion to work or any other physical activity for that is in the setting of if it was after a ligament tear or a joint capsule rupture or something that developed subsequently. Um, Again, non-occupational risk factors, we broadly don't know why these things develop. So that's why there's pretty much everything regarding ganglion. The second last one, I think, so for trigger digits. So trigger digits refer to a situation where there is pathology in the sheath, which is the little tunnel that the tendon that bends your finger goes into. So the tendon that comes up here, there's a little tunnel that it goes through, and if that sheath gets a little bit sticky or thickened, the finger can actually get stuck and it releases with a crack or a click. That's where you get the name trigger digit from. It sometimes goes by the name of stenosing tenosynovitis is another name for it as well. This is a condition that is, it's more common in middle-aged to older women as well. It's strongly linked with carpal tunnel syndrome. People think it's probably related also to carpal tunnel release surgery as well. It is a condition that is commonly seen in people who have got inflammatory or autoimmune arthritis conditions like rheumatoid arthritis or other inflammatory disorders like gout. It is again very common with diabetes or thyroid disease. These are again common risk factors that are also associated with carpal tunnel syndrome as well. Direct injury to the digit that injures the tendon sheath can certainly be reasonably associated with this condition. If the tendon sheath is injured, it will try and regrow, but it typically won't regrow exactly the same, and you can get some triggering subsequent to that. Whether it's associated with forceful activities of the hand is pretty controversial. Maybe is the answer there, particularly if it's associated with vibration. So again, the reviewers at the AMA guides, they find that there is some evidence for tasks requiring a lot of force and repetition or force in awkward postures. Again, this posture, if you've got the wrist flexed and you're using your fingers, is not a good posture. Like if you just sort of try it yourself, it's quite uncomfortable to flex your fingers with your wrist flexed like that. It's much less problematic to flex your fingers with your wrist in neutral or an extension. So again, maybe vibration, but some of these other things, we don't really think are associated. And again, come back to keyboards and computer work again, it's really not associated with this condition. These non-occupational, non-activity-based risk factors will very strongly mirror the ones for carpal tunnel syndrome. So conditions like diabetes, other underlying endocrine problems like thyroid disease or autoimmune inflammatory conditions. Again, bit of evidence for age and sex, but it's not as strong as things like diabetes. Same as the case for smoking there. So the last one that I'm going to talk about is one particular type of osteoarthritis, and that is osteoarthritis around the base of the thumb. We are typically talking about what we would call first CMC joints. So that stands for carpo-metacarpal joint. So around the base of the thumb here, where the wrist bones, the carpals, meet the metacarpal, which is the hand bone. it's a really classic site for osteoarthritis to develop. Now, osteoarthritis, of course, itself, it is a degenerative condition. It is an age-related constitutional or degenerative condition. So it is not a condition that is primarily caused by work or any other activity for that matter. The slight asterisk that we have there is that if a person does have a broken bone in the region, particularly if the fracture goes into the joint, then it is common, because the little bit of joint irregularity that can occur from that, that can actually progress the natural development of arthritis. So we get this notion of post-traumatic arthritis, where the injury has resulted in a greater or faster degree of arthritis than otherwise would have been the case. But it is primarily an underlying condition. And as I said, this is a really common place for it. Because it's a really common place for it, we do commonly get referred workers' compensation claims for here. Now, again, work will not have caused the osteoarthritis, but just like any other osteoarthritic joint, like an osteoarthritic knee or an osteoarthritic ankle, a person can still injure an osteoarthritic joint, and that is still a valid injury to that joint. You can have a soft tissue injury around a joint that has arthritis in it. If you have a twist or a slip or something, you can also aggravate or exacerbate symptoms related to it if you have trauma to it. So if a person with an arthritic hand or thumb falls onto their hand, then yeah, sure. From my perspective, that's a work-related exacerbation of arthritis in the thumb. So just because it's arthritis, I guess the point I'm trying to make here is that doesn't automatically mean that there is not also a work-related condition which can occur on top of the arthritis as well. So, I mean, are there any things that do this? So if people are working with forceful tasks in awkward postures around the thumb, there is some evidence, particularly if it's heavy forceful work, that that might exacerbate the arthritis in the thumb. Certainly, if you fall over and hit the thumb or land on your thumb, that can exacerbate the arthritis as well. But we always have to think very closely when we're assessing these types of claims, because a person doing any of these other things on this list, a person working in a cold environment, a person working with a keyboard, a person working with vibration, is going to get pain there if they've got arthritis that's flared up a little bit. But it's a matter of sort of trying to separate out what is a setting in which a person is getting symptoms from this underlying pathology, as opposed to has something actually happened at work or away from work, whereby a physical factor has contributed in a causative sense. In terms of non-occupational factors, I mean, very strong evidence for age. I think that's the first time it's seen very strong evidence. We know that as you get old, your joints wear out. It's an invariable part of aging. I often sort of use osteoarthritis as a bit of an analogy when I'm just trying to explain these conditions to patients I'm seeing, as an analogy for tendinopathy. So that rotator cuff disease, the epicondylalgia tendinopathies, I like to sort of refer to those as sort of wear and tear of the tendons, just like osteoarthritis is wear and tear of the joints. So we know as well that there's a very strong genetic factor to osteoarthritis. Now, some people are just kind of doomed by their genes to get more severe arthritis at an earlier age, and that does tend to run in families a little bit. Body mass index, so if you're carrying excessive weight, this is probably less of an issue for the thumb, but certainly for other weight-bearing joints, body mass index is a much stronger risk factor for osteoarthritis as well. But again, coming down, some of these other factors that we link with other conditions are not particularly well, not particularly as strongly associated. So how are we going for time? We're actually going pretty well. We're at about 40 minutes. So I was going to just talk really briefly, to step away from upper extremity conditions specifically here, and just talk about some things that I think are important from my perspective as a doctor when you're sort of trying to manage these claims. So I guess I'm sort of putting on the hat now, not as a doctor who is trying to treat people with these conditions, not even the IME doctor, but if, I was sort of consulting to an organisation, I do consult some organisations and provide some advice about how to manage certain claims. Some of the things that I'm really keen for people who are managing these claims to document. And really, it's those two things up there. It's just absolutely vital when you're managing any type of upper upper extremity disorder or claim, not just those as well, any sort of injury, we really need to get a clear diagnosis and we really need to get a clear mechanism of injury. These things are so important because firstly, an accurate diagnosis will guide treatment. It will guide return to work and prognosis. It's important that we try and get a specific diagnosis. We don't want someone to present a workers' compensation medical certificate that says they have shoulder pain or elbow weakness or tingling in the hand. Now, it's of course not always possible to get a specific diagnosis straight away, but there should be a plan to get a diagnosis. The other importance about these getting a diagnosis as well is trying to work out if the person has like a really serious condition that needs more urgent sort of surgical review, or if they've got really severe associated psychological ill health that warrants more urgent review as well. So try to pin down from the treating practitioners in this case, as someone who's managing a claim, what is the actual diagnosis is really important. Becomes important later on in the case as well. Sometimes if we then start to deal with sort of secondary conditions, knowing exactly what symptoms a person had and was presenting with at the time is really important, so that sometimes people will come back and say, well, look, I've been telling you this whole time that I had an pain in my elbow as well as my wrist. It's good to be able to look back and see if that had actually been documented. What about the mechanism of injury? Just talking, this is essentially how did it happen? Is the mechanism of injury is the fancy term for that. And as claims management professionals, you really want to get as much detail as possible. As doctors, you want to get as much detail as possible as well, because it gives you a clue as to what's likely to have gone on. So, is it possible to gather witness statements, contemporaneous reports and things like that? Because the things that I think are important from an organizational perspective after an injury is, okay, is the mechanism that the person is reporting caused their injury, is that consistent with what a person does in their job? So the person says that they were frequently lifting 20-kilogram boxes above shoulder height. Now, that's going to make them a bit of a sitting duck for rotator cuff tendinopathy. But as an organization, you want to think, okay, is this part of their job description? Now, if it is, okay, so we're going to tick in that box. I would suggest you probably need to be looking at your job description and saying that it's not a good idea for people to be lifting things regularly over 20 kilograms above chest height. But you make yourself satisfied that it is consistent. What if it's not consistent? Well, was there an emergency? Did something happen? Was there a fall, a spill? Was people rushing because of something? Why were things done outside the typical way, standard operating procedure? Why has that happened? Is the person carrying out the task contrary to how they're supposed to? Like, that doesn't change the fact that if something happens at work, it's still a workers' compensation claim. As you know, it's a no-fault system. But again, you want to know if people are not carrying out work tasks the way that you in the health and safety team potentially understand that they're being carried out. And I mean, I always encourage organisations that if a person sustains an injury and they were blatantly not following processes, as I said above, it's still a work cover claim. They're still injured. We don't be nasty to them about it, but don't be afraid to follow whatever your standard disciplinary or warning procedures are for a person not following procedure. I mean, that's not picking on a person who has had an injury. The person's not getting in trouble because they've had an injury. The person, is receiving a standard warning because they have done something the way that they shouldn't do. And I think that is always important. You might then come to the point, do work processes need to be reviewed because of that? You might even come to the case that you think, well, look, I don't actually think this happened the way this is reported. I'm going to ask the insurer to investigate this a little bit further. So all of these things are really important to work out in terms of when you're looking at the mechanism of injury, because at the end of the day, the question that is always going to come to the insurer, and the insurer may get advice from a treating doctor or an independent doctor about this, is the mechanism of injury consistent with the medical diagnosis? That is the central question in all matters of sort of, medical causation. So in the Queensland workers' comp parlance, it's, was employment a significant contributing factor? And what you'll probably be taking away from today is that sometimes this can be very complicated and not at all straightforward. A person who falls over at work and breaks their arm, that is really simple. And interestingly, whilst those higher traumatic mechanisms of injury often result in more significant acute pathology, those ones often get better a lot quicker and a lot more straightforward than some of these aggravations of tendinopathic type processes. So, I mean, when I am looking at this question, if I'm sort of wearing the hat as, say, someone who's on maybe the medical advisory panel who's been sent a request or seeing someone from independent medical examination, I'm going to look at the same things. I'm going to really be focusing on the diagnosis and mechanism of injury. I'm going to be trying to get some gauge of what of these sort of underlying or constitutional conditions or risk factors are present. I'm going to, again, go into quite a lot of detail about that mechanism of injury, and a bunch of other factors as well. And then essentially we just do our best to come to an opinion there. And, you know, the doctors on the medical advisory panel, we're not always going to come to the same opinion because, you know, there are just a whole bunch of uncertainties. You probably saw a lot of those slides up there. There was lots of, you know, uncertain evidence, low risk evidence. So it often does come down to a clinical judgment call, like in these cases. But the more of this information that you can send to the assessing doctor about the mechanism of injury, how work is done, you know, what was the actual weight, what is the cycle frequency of the tasks, right? Repetitive is used very, very frequently. And so, you know, how frequently is the task actually being done? What is the actual posture being involved? Don't just say it was an awkward posture. You know, this task requires the person to bend forward and reach up underneath behind a cupboard. That helps as well. So that was just a little bit of like some extra material I wanted to sort of mention at the end because it's particularly relevant to upper extremity conditions, but it's relevant to managing any sort of workers' compensation claim as well. So that's probably enough talking at you from my perspective. So I'm happy if there's any questions or comments that people would like to go through. I'm equally very happy for people if you need to head off and salvage the last 15 minutes of your lunch break. That would be great as well. I can see I do have one question. Hello, Carla. Hope all is well for you out there. So you've asked here about evidence base for Botox injections in the pec minor in the management of long-standing rotator cuff dysfunction. So in general, okay, so just into what are we talking about here? So botulinum toxin, just for people who are not so familiar with it, it is the Botox that is used in sort of facial cosmetic stuff as well. It is a toxin. It's a neurotoxin, which is increasingly used in clinical practice to either switch off nerves or equally to try and release tense muscles. So one thing that is one potential use that is being suggested now is for rotator cuff disease anyway, is to try and essentially paralyze part of that pectoralis minor muscle, which is a muscle which comes from your chest up to one of the points around the shoulder there. Now, this might be done either as sort of a trial to see if a more longer term process affecting that might help shoulder pain. I certainly don't think that it is a widely accepted treatment for rotator cuff tendinopathy in general. They often talk about, I believe, something called sort of a pec minor syndrome, which is sort of like a variant whereby it's thought that excess contraction of the pectoralis minor is sort of causing shoulder pain. So I think the short answer to the question, Carla, is that it's still a bit of a watch this space at the moment. It's certainly not primary management recommendation for rotator cuff dysfunction. I can see a question there as well from Kirsten. Thank you, Kirsten. Any upper limb informational studies on the injuries caused by the demands of driving and thoughts on driving upper limb conditions, particularly bus driving? Okay. So look, I would very rarely consider the act of long-term driving to be a causative factor for any of these conditions. Now, a couple of asterisks here. Um, if you are driving a vehicle for long periods of time that definitely has a lot of vibration through the steering wheel, then that question about prolonged vibration for carpal tunnel syndrome comes in, where again, we're probably talking more about an aggravation of an underlying predisposition to it, but there certainly is potential for that. But if a person's coming and saying, look, my rotator cuff tendinopathy or my tennis elbow has been caused by driving, if I'm wearing my IME hat, I'm very rarely going to agree that that is the case. I think driving long term is probably more likely to be a setting in which people experience some of this upper limb pathology. I'll just move on because there are a few questions coming up. So, Morgan, thank you for your question. So, with regards to epicondylitis and de Quervain's, if the symptoms are significant, how soon should a GP refer to a specialist, consider injections and seeing a specialist before having injections, etc., etc.? Okay, very fair question. So, look, the thing about injections is that most of the evidence for steroid injections does not suggest that in the longer term, it improves the overall prognosis or long-term prognosis for these conditions. In some people, it gets the symptoms to start improving a bit quicker than they otherwise would. There are some practitioners or what's the word I'm looking for? Some people think that inject sooner rather than later. You're more likely to then you can sort of get a little bit more benefit out of physiotherapy. If you've got less pain, you can get more benefit out of the physiotherapy. Other people will say, well, I don't really want to put a lot of steroid around that already tendinotic tendon because if we do it lots and lots and lots, we might contribute to a little bit more tendinopathy. Again, the jury's out on whether that's the case or not, but it certainly is a consideration. My general approach for these conditions is that I would start with the simple stuff: activity modification / modified duties, simple analgesia, physical therapy. The tennis elbow, there's no harm in putting in a counterforce brace across there as well. And I would probably try that for a couple of weeks. If the person is starting to get reasonable improvement, I'm not necessarily going to push them to get an injection, nor am I going to push them to go to a specialist. I'm going to pull those triggers if after sort of, a month or 4 to 6 weeks, we're not making any significant progress. That would be my typical approach there. Got a question from Narelle. Thank you, Narelle. Challenges for employers with aging population. Yes, many people have underlying conditions, absolutely, and claims typically get accepted for aggravations and exacerbations. Yes, insurers don't clearly determine when it ceases. Long-standing claims. Any advice how to prove the aggravation has ceased? Yep. Look, very, very, very valid question. And this, you're certainly not alone there, Narelle. There are lots of organisations that have this problem because, as you said, we have an ageing workforce. We also have a workforce in which people who are ageing are working in situations where they might be doing quite physical work. Aged and community care is a sector that I do a lot of work. It's a sector with a significantly aging workforce. It is not uncommon for people 60, 70 years old to be working in, aged and community care. And that's not easy work. I'm not sure what industry you're in, Narelle, but lots of industries have elderly, older people working in physical jobs. When has an exacerbation or aggravation ceased? There is no exact science to this. The approach that I would take when I get a question like this, either through a medical advisory panel or for an IME, is I will look at, okay, what is the degree of underlying or the extent of degenerative disease there? Like, is this shoulder, have we got severe tendinopathy in all of these tendons? Or, have we got a not too bad looking shoulder? We might have one or two tendons that are a bit thickened and a little bit of bursitis. And so I look at that. I'm going to look at what was the mechanism as well. Was there actually trauma to the shoulder, or was there just a bit of pain lifting something up that wasn't particularly heavy? I'm going to look at the progress that has happened. I fully accept, and 95% of doctors are going to accept, that a person with a tendinopathic shoulder can still get an injury or exacerbation thereof if something happens at work. But the thing is, we would expect that that injury, that exacerbation or aggravation would improve with fairly conservative measures. So some physiotherapy, maybe an injection over a period of a couple of months. So if the person has had that and they had a very small amount of improvement and then they just hit a plateau and it hasn't improved for months and months more, I'm more likely in that setting to think, well, we're probably back to the baseline of where we were from your tendinopathic shoulder. So I use that as one potential marker. Um, Again, if there's more significant trauma, I'm more likely to accept that the degenerative condition or the aggravation thereof may go on a little bit longer. I mean, people often talk about, the 3-month rule. I mean, the 3-month rule is not a rule. I mean, it's just this general idea that for non-specific soft tissue injuries or exacerbations, most people we would expect to be significantly improved by around that 3-month mark. Some people take 3.5 months, some people take 2 months. Though, for every most normal people, there's still a 5% of normal people that will fit outside that. So if I'm set a person at 3.5 months who is recovering reasonably well and is still undergoing physiotherapy and still feels like they're improving, I'm likely to say, yes, look, this person does need another month of physiotherapy. But again, if I get the person at 4 months and they said they've got a bunch of improvement for 1 month, but then despite further physio and injection, I haven't improved any further, then I'm likely to say that's probably. You need to, I guess, be talking to the claims managers who are looking after your claim at work cover, and trying to be proactive about that, looking into that, asking the questions. At the end of the day, sometimes though these things do have to go to independent advice because often treating practitioners are a little bit hesitant to sort of make that call to say that it's now related to the underlying pathology, and claims managers at work cover, they can't make medical decisions themselves. They have to go off the medical advice they're provided. So sometimes you do have to sort of push them independent opinion a bit more early. I can see sort of follow-up question, would the tendon issues have occurred irrespective of work? I mean, yes, they would. I mean, tendon wear and tear breakdown will occur irrespective of work. A couple more questions. I'm aware of time now. I can just see you've had one more thing there, Narelle. Hard to get IMEs. Yeah, I don't disagree with you. New tender coming up for IMEs next year. Maybe we might get an expanded panel. I know it's a difficulty. I can't sort of really suggest anything more beyond that, other than I suppose, if you've got concerns that a case is going to go bad early on, maybe request for an IME, even just to temporarily book one in the future. But it's kind of more something you need to sort of speak about with your claims manager. Just quickly going through the last couple of questions. So Katie Jenkins, thank you. So if workers haven't been accessing prior treatment, but the condition was underlying the workplace is simply the setting, how can we ensure insurers are accepting that rather than injury caused by work? So, I mean, I guess, if you're sort of taking, good details of what the mechanism of injury was and providing that to the insurer and providing the insurer with concerns about underlying conditions, the insurer can then ask the treating practitioner, what, is this an exacerbation as opposed to an aggravation? Again, the insurer's hands are tied in some sense in that they have to go off the medical advice that they're provided. So, you or even I may disagree with the advice that the GP has given regarding whether a condition was pre-existing or not, but in the absence of that, kind of the only option that the insurer has is to seek independent advice, which has cost and time limitations. So I think just staying in contact with and talking to people is really important about that. I've got a couple more questions. Latest evidence with respect to fractures that cause frozen shoulder in the absence of significant injury. So look, frozen shoulder certainly is a complication of traumatic injury to the shoulder. Surgery to the shoulder. Diabetes is a very significant risk factor for frozen shoulder as well. I know that we do see cases now of claimed frozen shoulder after very minor or non-specific incidents at work, and I personally would be somewhat hesitant, particularly if the person was a diabetic, to attribute that to a minor non-specific incident. If there's no injury at all, and it's just this idea of, general repetitive use that's caused my frozen shoulder, I think there's very little evidence to support that. But often the claims that I see in this regard are a person who's got a claim for rotator cuff tendinopathy and bursitis due to actions at work, which has been complicated by frozen shoulder. I've got a bit of a difficulty with that because I still think that frozen shoulder evidence more comes down to more major trauma or surgery. But I think, Adam, it's fair to say that there isn't universal agreement in the orthopedic field about that at this stage. And Jason, maybe the last question. Jason Berry, thank you. I think we place of PRP injections in injury management. So look, I think the evidence for PRP is still evolving. The evidence is still not to the same level as the more traditional treatment modalities, which is the basis for the current workers' compensation guidelines, that it's generally not covered. I would agree that PRP is getting a stronger evidence base behind it than it was. I suspect there will come a time where, in certain circumstances, it might be accepted in certain workers' compensation situations, but at the moment, the evidence is just not supportive. Lots of people will get it anyway, get it through the Medicare system as well, external to the claim. There are some people who swear by it, some people don't, and that's the whole, sort of lack of evidence thing. So given that we are now over time, I think I have responded to all the questions in chat. So thank you very much to everyone for taking your time. Thank you everyone for engaging so much at the end with all of your questions. That makes it a lot more interesting to me. So I hope everyone enjoys the festive season. And if there's anything in this regard that we can assist you with, this really is one of our bread and butters as occupational physicians, working these things out. So if there's any way we can assist either individual cases or sort of just any more consultancy that you'd like, please don't hesitate to get in contact with us. But otherwise, thank you very much.